Hello, this is Professor Nahas, and this talk is about critical appraisal, and in a way it complements another talk in your curriculum called the 5 Whats. Emphasis here will be on critical appraisal of the literature, of published literature, and more specifically on published clinical trials and randomized controlled trials and clinical investigation that you come across in your readings and in the literature and upon which you base your daily clinical practice. And we'll compare critical appraisal in a way to detective work. You're there with your checklist, studying and evaluating and ranking and scoring almost every element of the publication to conclude for yourself, not what the authors concluded, not what the publisher concluded, but for you to conclude for yourself whether the evidence reported in this particular publication is correct, strong, valid, and whether it is useful. And you look at every aspect of the study. All too often, you are of a generation where the internet made accessible a huge amount of medical publication, and very often all you need is read the title and take it for granted. New miracle drug for renal transplantation. You learn the name by heart and you go around saying, oh, there is a new miracle drug that induced tolerance in renal transplantation without reading further. Or you might read the abstract, again on the internet or elsewhere, and take on board the conclusion of the authors and the conclusion of the abstract that there is a miracle cure for CKD, or a miracle cure for acute cellular rejection, or a new miracle cure for antibody-mediating rejection, and you take it on board without reading the publication in details, as it may be invalid, therefore the conclusion are not built on solid evidence, and it may be totally useless to your own patient pool and to your own treated population. And that's exactly what we will put emphasis on. The validity of studies, problems with published studies that you need to identify and be familiar with, and how useful they are to your own medical practice. So the two questions we'll be asking: is the study, is the publication, are the findings valid, and are they useful? What does valid mean, and what does validity of a given trial, clinical study, randomized control trial mean? There are many points that determine the validity of a clinical trial, including the randomization, including the blinding, whether it's single-blinded or double-blinded, including whether the study is large enough, the sample size, whether the design of the study and its conduct is adequate, whether the statistical analysis of the study is justified and correct, and whether the method and the endpoints used for the trial are satisfactory, whether the data interpretation of the results of the study is correct, and whether the final conclusions of the study are justified. The first question we always want to look in a publication, in a clinical intervention, in a clinical trial, is what is the aim and what is the precise question that particular study asks. We need to be very clear, and that's usually what is described as the primary endpoint of the study. Okay? So the primary endpoint is the primary question of the study. I want to study an intervention that decreases the incidence of biopsy-confirmed acute rejection. Clear and precise. I want this particular study is evaluating an intervention compared to placebo to treat antibody-mediated rejection. Clear. So we're looking at antibody-mediated rejection incidence as the primary endpoint. And that's important to bear in mind. So we need to be clear what is the primary question. We'll see later on that you can have secondary questions. So you may look at the primary endpoint being biopsy-proven acute rejection, with secondary endpoint, kidney function, proteinuria, doses of steroids, and so on. And we'll see that the secondary endpoints are supplementary questions, but the study is not designed to address them. The study is designed to address the primary focus question, the primary endpoint. It's important to know whether the study is randomized or not. Randomized means that the groups within that study are randomly allocated to one or the other form of treatment. So they're not prejudged. So it's not as if we'll put all women in one group, all men in one group, give all the men the intervention, the new drugs, give all the women the placebo, and then compare the outcome. No, we want a randomized process so that equal number of women and equal number of men feature in each group, and so on and so forth. And this has to be described. So when you look at a clinical trial publication, make sure that it is randomized and controlled. Make sure that there is a controlled group, but also make sure that the randomization procedure is well described. And this can be done in many, many ways, increasingly computerized, and the actual publication should tell you how it has been achieved. Are the groups well balanced? Hopefully, the randomized process and the randomized allocation of patients to different experimental group will lead to a balanced set of patients in each group so that the comparison can rely primarily on the intervention and leading to the outcome, and not on confounders due to the fact that there are more women in one group compared to the other, there's more blacks in one group compared to the others, patient in one group have a mean age of 20 compared to the other group where the mean age is 80, and therefore not comparable. Okay? Is there a bias? What is a bias? A bias is a factor within the design of the clinical trial that risks to produce an abnormal result independently from the intervention we're looking for. We want to equalize everything. We want to exclude bias. So whatever result we get is the result of the design and the intervention we are studying. And there are different types of bias. Randomization bias, where, as we said, one group is different from the other. Selection bias, where you decide to study only people over the age of 80 compared to another group of all comers. So that's not accurate. When you decide to study patient with progressive, let's say chronic rejection for a better word, but you select those without proteinuria, and then you can't generalize the result because there is a bias from the onset. What is equally important is the observer bias. That's why most randomized controlled trial should be double-blinded. What do we mean by double-blinded? We mean that the patient doesn't know what he's taking, whether it's the placebo or the intervention drug, but also the investigator, the physician who is monitoring the study, who is evaluating its outcome, doesn't know who is taking what. Why? Because if the investigator knows that this patient is taking the active drug and this patient is taking the placebo drug, it may indirectly affect his behavior in terms of monitoring perhaps more closely those on the active drug, following them up at the clinic more often, knowing that there's no point following those who are on the placebo. And in doing so, by impacting on selection, on follow-up, on patients' evaluation and management, indirectly affect and bias the outcome of the study. So it's important to score highly studies that are randomly allocated, randomized, but also double-blinded with a control group with both the patient and the investigator. Open label means that the investigator or the treating doctor knows what he's given the patient, therefore it is not double-blinded, therefore automatically it is potentially subject to an investigator's bias through selection, follow-up, excuse the mistyping there, and management. Attrition bias is also important. Attrition bias means the loss of patients, perhaps in one group, to follow-up or to evaluation compared to the other group. It may be that the active treatment group has too many side effects. So many stop taking the drug, don't come back for recording, drop out of the study, and those who are left in the active group are those with higher tolerance, stronger ability to tolerate the medication. And this can create an imbalance between the groups due to the fact that patients with side effects, mild, severe, or even death, drop out, so are no longer accounted for, giving the false impression that the treatment is effective and harmless, where in reality, if we had included them in, we realize that it's potentially harmful. So the risk-benefit is different. And this is why all patients in a clinical trial, from the minute they take the first tablet on the first day of the clinical trial, should be accounted for in the final analysis. And the researcher should check that the evaluation and the calculation include all patients in both groups. And this is what we call intention to treat analysis. Anybody who was randomized with an intention to treat, either by placebo, either by observation, or by an active treatment, should be included in the final analysis. Compared to per protocol, which is the analysis of those who finished the study only, discarding and not analyzing the others who may have dropped out because of problems, side effects, morbidity, or even death. So it's important when you look at a clinical trial and a publication to look at the statistical analysis description and make sure the authors say intention to treat analysis was performed on all the participants of the study. If they don't say that, it always leaves me with the suspicion that the study is per protocol, and that's less satisfactory, and for some reason they haven't analyzed everything. Because if you do analyze everybody, you say it. If you don't, you tend to skim over it and not mention anything. Performance bias is interesting. This is another bias when the outcome may have been affected by the actual conduct of the study rather than the actual intervention. And this is even more important when the doctor knows what history. So let's say the doctor is running a clinical trial on a drug to lower lipids and decrease chronic rejection following renal transplantation. He knows that one group is taking a lipid-lowering agent and the other a placebo, so he brings the group that is actively treated more frequently, see them more carefully, measures more parameters, and in the process may also control their hypertension. In the process of seeing them more frequently may improve and adjust their immunosuppression drugs and adjust other parameters, therefore improve the performance of a group at the expense of another group which is somewhat neglected, leading to better outcome of the improved performance group, which is not necessarily due to the actual intervention that he was testing. So unblinding can risk performance bias by the investigator, leading to better performance, better overall management of one group over the other, and consequently better outcome, maybe unrelated to the underlying primary endpoint and primary trial question. An important point to look for in published clinical trial is the sample size. The study has to be big enough, based on certain parameters that we'll mention briefly, to ask the specific question aimed for, i.e. the primary endpoint that we're looking for. Survival, hospital admission, decreased rejection, increased survival, and so on. Any study with an inadequate sample size runs the risk of giving you spurious results that are not statistically sound. So yes, size matters when it comes to sample size. So you want to minimize false positive results. You want to minimize false negative results. You want to be able to have an idea what you expect the difference between group A and group B. In other words, 20% improved survival, 25% difference in survival, 30% difference in acute rejection, and so on. And if the sample size is inadequate, the study can conclude that there's no difference between the control and the intervention population, and this could be due to a statistical bias, in other words, a statistically mistake called type 2 error or beta error, where if the study was larger, if the study was better powered, it would have led to a positive result and not the nil difference between the two groups. Or you can have a false positive. You get the impression that if you compare 10 and 10, 6 in one group respond compared to 2 in the other group, so you say there is a difference. But that's only because the sample size is too small. Had you compared 100 patients in group A versus 100 patients in group B, you may have found that there's no difference. But because the sample size is too small, it led to a type 1 alpha error because there wasn't enough patients to even the two groups up and come up with the proper statistical result. So the first thing is you want the power of the study to be high. In other words, I want the study to have a chance of 80 or 90% to detect the difference. I want the highest possible probability that I will not get a false negative. So 80%, 90%. If the study is powered only to have 50%, then it's meaningless because 50-50, then it could be either positive or negative. So the higher the power, you set for your study, the higher your ambition to get a truly positive result, the better. So that's the power, probability of not getting a false negative result. The level of statistical difference, the t-test or the p-value, is the probability that we have a false positive result. So we want the probability of having a false positive less than 5%. We want the probability of not getting a false negative 80% of higher. And if you know the expected difference between the two groups that you hope to achieve in terms of your primary endpoint and the variability between the groups and the duration of the study, you could come up with a sample size estimation that is most likely to avoid giving you a false negative and avoid giving you a false positive result. That's why the sample size estimation has to be described. Why did they compare 249 patients to 248 patients? Why not 500 with 500? Why not 50 with 50? It has to be explained, and they have to give you the power in the publication under statistical analysis of the study in the methodology section. They have to give you the anticipated p-value, and they have to give you why they've chosen the number based on previous study showing you the expected effect and difference between the groups. Now we come to data interpretation and primary endpoint. So the primary endpoint is important, and that's the single most important parameter upon which the whole study is based, upon which the statistics and the power and the sample size is calculated to reach a result. And always remember, a result doesn't have to be a positive result, doesn't have to be a negative result. A result is a valid result, whether it's positive or negative. And then we need to see whether the interpretation of the result and the data is correct. So let me stop here for a second and flash some warnings, health warnings. Beware of. Studies are planned and designed and powered based on the primary endpoint. Secondary endpoints. Post hoc analysis mean that when the study is finished, you carry on and you analyze another group for a bit longer. Perhaps if we follow them up for another 6 months or another 8 months, we may get a result. Subgroup analysis, when Group A versus Group B did not show any difference. Well, let's go and see if in females there is a difference. Let's go and see if in the elderly there is a difference. So you take a subgroup and you compare it with another subgroup. These are not subject to statistical analysis. They are at best hypothesis generated. So maybe the females do better than the males. This is something to be flagged out so that another study can confirm it. But subgroup analysis, post hoc analysis, secondary endpoint results are not validated for the simple reason that the study is not designed to address them statistically. Another warning is the excessive use of composite primary endpoint. So you'll say, I look at myocardial infarction and or stroke and or mortality and or hospitalization for peripheral vascular disease and or quality of life. And by using many, either interrelated or not interrelated but with different importance to the patient, quality of life may not be as important as death or survival, and mixing them all in one composite endpoint, you may end up having significant changes in the quality of life, but because it's part and parcel along with survival, it could give the impression that the primary composite endpoint is improved by the drug, when in reality, neither hospitalization, no patient survival, no strokes, no heart attack, only quality of life made a difference, but it gives the false impression that the primary endpoints have all been improved. So I want you to read about composite endpoints, and I want you to understand the risks and danger of using them inappropriately. And the last warning is be careful with meta-analysis. Well, what is a meta-analysis? Meta-analysis is when one study didn't show a difference, 2 studies didn't show a difference, 3 studies didn't show a difference because there were 1 badly conducted, 2 unblinded, 3 underpowered, 4 too small a sample size. Then you put them all together in one pot. Suddenly you have a bigger sample size, maybe better matched groups, and then you reanalyze and you conclude that there is an effect. Just from my description, you can see the risks. Study 1 is not comparable to study 2, is not comparable to study 3. Study 1, 2, 3, 4 are individually flawed. So you take bad studies in a given example, mix them all together, and imply that you're getting one larger data set and analysis that will give you a more definitive diagnosis. So the heterogeneity of the studies may not allow for such analysis. So don't assume that all meta-analyses are correct. Don't assume that meta-analyses are the ultimate solution, for the simple reason meta-analysis combining many studies are as good as the components, in other words, the individual studies that are included in the meta-analysis. Also be careful with data interpretation and surrogate endpoint. The primary endpoint may be changes in albuminuria, looking at chronic allograft survival. But the surrogate endpoint assumes that a change in albuminuria will invariably translate into better allograft survival, and that is not always the case. Reduction of LDL and increase in HDL or changes in serum lipids will always translate into improved cardiovascular survival. That's not always the case. So you do an intervention, you see a surrogate endpoint, and then you imply, rightly or wrongly, that is the problem, that it will impact on hard endpoints such as survival, such as hospitalization, such as graft loss. These are hard endpoints in transplantation. The graft is lost, the patient is lost, or the patient is hospitalized, morbidity, or the patient has major adverse cardiovascular events, MACEs. These are hard endpoints. Another example is, for instance, changes in left ventricular mass, implying that if an intervention reduces left ventricular mass, it will improve cardiovascular disease and will prolong survival. Not necessarily the case, and so on and so forth. In renal transplantation, you find that the majority of studies have looked at the primary endpoint of decreasing biopsy-confirmed acute rejection, BCAR, or biopsy-proven acute rejection, BPAR. Assuming that if a patient has less rejection during the first 3 months, 6 months after renal transplantation, he'll have a better 1-year function, he'll have a better long-term graft survival, and he'll have a better patient survival. Not true, because there are variables, there are mild rejection that don't impact on function, graft survival, or patient survival. There are moderate rejection, which may not be the case, and there may be severe rejection that may impact on renal function and graft survival. So again, be careful when you look at trials relying on renal biopsy without specifying its severity, without specifying its Banff classification, because this is also potentially a soft surrogate endpoint, not a hard one. The only two hard ones in renal transplantation will be graft survival, patient survival. Take the example of changes in serum creatinine following renal transplantation. And if we use estimated GFR and we calculate the GFR from serum creatinine level, and we imply that changes here are directly related to change in kidney function, not true. Patient can be ill, wasted, sick, decreased protein intake. This would lower his serum creatinine. Can be wasted, sarcopenic, with decreased muscle mass. This will decrease creatinine generation. There may be changes in tubular secretion with a given intervention. This will not affect GFR, but will reduce or increase serum creatinine levels. Also intervention, take steroids for instance, affect muscle mass, leads to muscle and proximal muscle weakness, lead to muscle wasting. This could itself impact on serum creatinine level. Nothing to do with GFR. So be careful. Serum creatinine, estimated GFR, regardless of the equation, can be confounded by 4 variables. Always to bear in mind, and don't assume that serum creatinine and eGFR are always markers of progressive renal function. So you see, validity has many components. What about utility and usefulness? Well, it's mainly the question is, this is an intervention that is valid, convincing, correct, not flawed, but is it applicable to my patient? Is it applicable to my local population? Is it relevant to my patient? Just to take an extreme, an intervention that is protective in renal transplant allograft against a high incidence of prostatic cancer will not be relevant in females who are allograft recipients. An intervention which is focusing on Black African Americans may not be relevant to your population of Egyptian or North African or Middle Eastern or Asian individuals. And also we come back to the 5 whats. Having said that the intervention is effective, what is its risk-benefit profile? What is its cost-benefit analysis? Because it may be beneficial, it may be justified, but the risk is too high. It may be justified, but the cost is too high. May be justified, but the number needed to treat is too high. You have an intervention which is very effective, but in order to increase allograft survival in one patient, you need to treat 1,000 patients. That is not neither cost-effective nor risk-benefit favorable. So the number needed to treat is important. And an intervention which is significant clinically has to have a low number needed to treat. So you treat 5 patients with this drug, you save 1 kidney. You prolong the survival of 1. You treat 10, less than 100. But the intervention can be statistically significant, but totally clinically irrelevant because the number needed to treat is far too big. So another concept to bear in mind and read about is the concept of number needed to treat, to justify, to make the intervention useful. So there we are. We have quickly went around the validity and the utility of clinical trials. And I'll leave you with a checklist. Is the study randomized controlled? Is it double-blinded? Is the randomization detailed? Is there a bias? Is the sample size estimation detailed? Is the dropout and not accounted for in patients or individuals more than 25%? Is the analysis intention to treat taking everybody into consideration or not? And then you can score, and we'll give you a template that would allow you even to put a score and a number on each trial. Is the study applicable to my patient, to my society, to my country, to my health economics? Is the number needed to treat, not included here but should be included, number needed to treat, is it less than 100? Is it low? Therefore making the intervention cost effective. If I treat a small number, I'll gain. But if the number needed to treat is too big, then it's not cost effective. I don't want to treat 10,000 to prolong the survival of one. So read your articles. Don't just justify your conclusion and your learning and your practice by reading abstracts and titles. Read and read carefully, read critically. Yes, you can. And if you overcome the laziness in a way of trying to read carefully and evaluate the evidence thoroughly, yes, you can appraise trial, and yes, you can improve your own practice. And this will lead to a very important concept in our medical practice, is the more informed we are, the more critical we are, the less harm we'll subject our patients to. So I'm giving you here some references. I want you to go to the internet and look at CASP, look at criticalappraisal.com, and look at a number of resources and familiarize yourself and even test yourself, and many of these are freely available on the internet. So we would advise you to complete a self-training online on critical appraisal, and we'll ask you, part of your introduction months, to provide a mini essay of 500 words on critical appraisal, its process, its value, and its application. We also want you to comment on issues relating to clinical trials in nephrology and appraise randomized controlled trials of your choice in renal transplantation. You can test yourself and test your knowledge with this question, or with that question. And this concludes our talk on critical appraisal, part of your transplantation online course. Thank you very much for your attention.